Hello and welcome to the Living With series. My name is Claire Crisp. I'm with the Hypersomnia Foundation, and today I have the pleasure of introducing you to Dr. Lynn-Marie Trotti. Dr. Trotti is the Associate Professor of Neurology at Emory University in Atlanta, Georgia. She graduated from Baylor College of Medicine and completed her neurology residency, sleep fellowship, and Master of Science in Clinical Research, also at Emory. Her main area of clinical and research interest is now the central disorders of hypersomnolence. Dr. Trotti is funded by the National Institute of Health and the American Academy of Sleep Medicine Foundation as the principal investigator for 2 clinical trials investigating treatments for hypersomnolence. In today's conversation, we learn why Dr. Trotti became a sleep specialist, her origin story, her focus around comorbidities, particularly mental health that's associated with idiopathic hypersomnia, and clinical trials. So let's hear from Dr. Trotti. Dr. Trotti, welcome to our Living With series for the Hypersomnia Foundation and our amazing community. It's really such a privilege and a pleasure to have a few minutes with you. I know that you have so often actually given your time and expertise to our patient community, so it's particularly exciting today that we can maybe do a deep dive into some particular topics. So thank you and welcome.
Thanks so much for having me.
Okay, so I'd love to start with actually a little bit about you as a doctor. How did you get to where you are right now? And what was it about sleep medicine that was so compelling that you should dedicate your career to?
So, I am trained as a neurologist. I went into neurology, I think, for the reason lots of people do, which is that the brain is really fascinating. And as much as we understand about the brain, there's even more that we don't understand. And so that makes, I think, for an exciting career. When I started my neurology training, I was not intending to be a sleep neurologist. Sleep really wasn't on my radar as a career. But I was fortunate enough to meet some sleep physicians in my training. And I really loved a couple of things about the field. One was that same sense of unknown and questions that drew me to neurology. There's a lot that we know about sleep, but there's so much that we don't know about sleep and sleep disorders. And I really could see that over the span of my career, the whole field was likely to change. And I found that really exciting. Um, the other thing that drew me to it was just the one-on-one aspect of it. There's so many disorders in sleep for whom you can really improve people's lives by fixing their sleep disorders. You can really improve people's quality of life. You can improve their functionality, their sleepiness, their health for some of these disorders. And I was really drawn to the impact that I could potentially have on patients in a field like sleep.
Yeah, that's a good reason. So just for our audience, how much of your time is spent clinical in the clinic with patients, and how much is as a researcher?
So I see patients in clinic just 2 half days a week. And then I spend about a half a day a week reading sleep studies of various kinds. So that's clinical work, but not one on one
Okay.
with patients. And I do a little bit of administration and teaching. I help lead our fellowship program, training new sleep docs. But the rest of it is research. So quite a lot of it is research.
Okay. So to bring us up to speed on, or even perhaps looking a little bit back, how do you feel like the landscape of sleep research has changed over the last, say, decade? Where is it now? What's your role in it? And perhaps then the next question is, where do you see it? But let's start with giving us a bit of a retrospective view of, how you've seen research progress.
Yeah, I mean, I think it's been a really exciting time to be in sleep research, and particularly a really exciting time to be in idiopathic hypersomnia and narcolepsy research. Um, when I started out, albeit a bit more than a decade ago, there really was just not a lot being done in studies looking at idiopathic hypersomnia. And it really felt like kind of a void. There was some work, but there wasn't nearly enough. And that's really starting to change in a way that's exciting. Of course, there's still not nearly enough. We have tons of work to do in IH, but it really feels like there's this momentum building, that there are more and more people interested in the questions about idiopathic hypersomnia, and more studies being done specifically in people with idiopathic hypersomnia. And I think that's really exciting.
Yeah, how do you explain that? Because I mean, I've seen that progression in terms of, yeah, I suppose research and also drug development, but it's hard to sort of pinpoint exactly where that sort of pivotal moment was, if there was one, where suddenly there's like more interest and more need. Any thoughts on that?
I don't know that there's been sort of a one pivotal moment or one pivotal discovery that got
Right.
everybody interested. I think it's maybe more of just a critical mass. A few people start asking questions, and then they get other people interested, and then those other people start asking questions. I do think the first FDA approval of a treatment for idiopathic hypersomnia was an important inflection point.
Right.
Not necessarily because that's the right drug for everybody with IH. It is for some people and is not for some people. Um, but because it was a signal to other people interested in drug development that this is a disease that the FDA
Mhm.
acknowledges. You can do a well-run clinical trial in patients with IH, and it can lead to a drug approval. It sort of took some of the risk and uncertainty, I think, in
Right.
drug development out of the equation.
Okay. Do you mind saying a bit more about that FDA approved drug and where that leaves us kind of going forward with more opportunities for medications for people with IH?
Sure. So the one drug that's currently FDA approved for IH is a drug called calcium, magnesium, potassium, sodium oxybate, which is a mouthful I've gotten very good at saying. Usually referred to by people as lower sodium oxybate or mixed salts oxybates. It has a few nicknames because its name is kind of unwieldy. And basically what it is a repackaging of an older drug. So there's a drug that's been approved for narcolepsy for about 20 years called sodium oxybate. And although sodium oxybate's never been approved for idiopathic hypersomnia, it was one of those narcolepsy medicines that we sometimes used off label. We sometimes treated
Mm.
people with IH with it, even though they didn't have narcolepsy, because there wasn't anything approved on label for IH. So when lower sodium oxybate was developed, you kind of get a sense from the name, the difference in the two drugs. It's the exact same active ingredient. They both have oxybate. It's like 1 to 1, the same amount of oxybate. All that's different is the amount of sodium that's kind of stabilizing the drug. There's quite a bit of it in sodium oxybate, and there's quite a bit less in lower sodium oxybate. So we don't necessarily expect the drug to behave all that differently uh, from sodium oxybate. But what was novel about this drug is that the drug company did study it specifically in a trial of people with IH. So unlike before, where we said, well, there's studies in narcolepsy, let's just hope it works in IH. Now there was actually data that lower sodium oxybate helps for people who have IH. So that was the first drug to get FDA approval. Hopefully, won't be the last.
Yeah, perhaps maybe give us a bit of a landscape of what potential medications might be upcoming for people with IH in terms of research and clinical trials. What can people kind of learn from this conversation in a way that might give them hope?
So, I think the landscape has more drugs in it that might be tested for IH than it has in as long as I've been doing this, and it wasn't any better before I started. This is sort of uh, a new time for IH in terms of there's multiple drugs that are being potentially looked at, multiple companies who have some interest in trying to see if they have a drug that's a good fit for people with idiopathic hypersomnia. So I think that's really exciting. The one that's probably the one to watch because it's the closest to having new results. Is for a medication called pitolisant. So this is a medicine
Hmm.
that's been FDA approved for narcolepsy for about 4 years now. In the studies of narcolepsy patients, they mostly had narcolepsy type 1, so the kind of narcolepsy that's more different from IH. Um, but it's been available for people with narcolepsy for several years. It's not a medicine we can easily prescribe off label to people with idiopathic hypersomnia. It's not one we can usually get. So, at least in my experience, most people with idiopathic hypersomnia haven't had a chance to try it.
Hmm.
But the company is doing a phase 3, so a big controlled clinical trial of pitolisant in people with IH.
Right.
And they announced a couple of months ago that they had enrolled their final participant. And so that's a huge milestone. That means all the participants who are currently enrolled have to get finished, and then they'll be able to look at the data. But in the lifespan of a clinical trial, that means we're actually
Hmm.
pretty close to the end.
Hmm.
Of
Yeah.
course, none of us know what the results are going to show. I don't know if it's going to work for idiopathic hypersomnia or not. I think there's plenty of reason to be optimistic that it will. But we won't know until we see the results.
Right.
But if that trial, in fact, shows that it helps for people with IH, one assumes the company will then go to the FDA and try to get FDA approval for IH, which uh, would be a big deal. It
It
would
would be.
open another avenue of treatment for people with IH. And I should say it's not just that it would be another drug that's like other drugs that people with IH have already tried. Pitolisant is unique in how it works. It works on the histamine system in the brain. Histamine is one of the chemicals that's important for being awake. If you think, even people without sleep disorders who take antihistamines tend to get
Hmm.
sleepy as a side effect, and that's because you need histamine to be awake. And so pitolisant works by increasing histaminergic neurotransmission in the brain, which none of our other narcolepsy medicines do at this point in time. And so while IH patients have often tried lots of narcolepsy medicines off label, like modafinil and traditional stimulants and what have you, pitolisant is substantially different than anything most IH patients will have tried.
Can you speak to what symptoms pitolisant might address in people with IH, of course?
So it is a daytime wake promoting medication. And so it's a medication that, at least in people with narcolepsy, is taken once a day, first thing in the morning. And so the main thing that it is trying to target is sleepiness. In people who have narcolepsy type 1, they also have cataplexy, these attacks of a sudden loss of their muscle tone triggered by emotion. We don't see that in IH. Pitolisant does happen to help with cataplexy as well, but within IH, sleepiness would be the main treatment target.
Okay, daytime sleepiness. Thank you. Okay, so I know quite a body of your work and expertise, Dr. Strotty, has focused around comorbidities in sleep disorders, particularly IH. And I think this is a really tricky subject because sometimes our community experience lots of, not sure whether they're side effects of medication or actually organic illnesses related to IH. Could you speak a little bit to perhaps some of the main comorbidities that you would want people to be aware of potentially once they have a diagnosis of IH?
Sure. So it's a bit of a tricky subject to navigate clinically and research wise, because right now the way we diagnose idiopathic hypersomnia is by saying you have this set of symptoms and you have this set of symptoms of findings on your clinical testing, like your sleep study testing, and then we rule out everything else that might be causing the sleepiness. And only when we sort of
Mm-hmm.
have all three of those pillars, the right symptoms, the right testing, and ruling out of everything else that might cause sleepiness, do we really say it's idiopathic hypersomnia. So a purist might say you actually can't have comorbidities with idiopathic hypersomnia. You can just have idiopathic hypersomnia and no comorbidities that could possibly cause sleepiness. And for some kinds of research studies, that amount of precision is really important.
Mm-hmm.
But what happens, of course, in the real world is that people aren't limited to having only one thing, right? People can have more than one disease. It happens all of the time. Um, and so it can get a little bit hard to know, does this person have IH and another disease that can cause sleepiness or can cause some of the same symptoms, and they really have both things? Or is this other comorbidity actually masquerading as IH and I don't have IH at all? And that can be really tough to disentangle. Um,
Mm.
when we have a way of diagnosing IH someday that gets at the underlying biology, where we can sort of do a blood test or a spinal fluid test or whatever it is and say,
Mm.
oh, well, you have this chemical imbalance or whatever it turns out to be, you have IH, these questions will get much easier to answer. But for now, we're sort of stuck in this a bit of a murky area
Mm.
about maybe what's what's a coincidence and what might be a cause, and what really um maybe are some of these other
Yeah.
disorders telling us about IH. So I think, you know, one of the situations that we encounter most commonly in practice is people with IH who also have depression symptoms. So there is a disorder called hypersomnia associated with a psychiatric disorder, which literally means you have hypersomnia symptoms and a mood disorder, and that's what you need to make that diagnosis. So technically, people with IH and depression might fit better in that category. Um,
Mm.
but also, when you try to give someone that label, you're kind of supposed to make sure you don't think they have IH more, and that can be tough to disentangle. I think this is one of those situations where the relationship probably goes in all the different directions. So we know that depression can cause hypersomnia symptoms. We know that depression can cause sleepiness. We know that depression can cause great difficulty waking up in the morning, the sleep inertia that we see in IH patients. Um, we know that people with depression who have hypersomnia sleep longer than people without hypersomnia. So, you know, we know that depression can lead to the core symptoms of hypersomnia, and that's important.
Mm.
Um, we also, I think it's very plausible that someone who has IH first could over time develop depressive symptoms in reaction to
Right.
their hypersomnia. Not
Right.
everybody does, but certainly, you know, living with IH, you don't need me to tell you, carries big challenges. It can impact every facet of someone's life, right? Your relationships, your work, your school, your ability to take care of yourself. Like when it's severe, it bleeds over into so many aspects of life that a certain number of people will probably develop some depression symptoms in reaction to that. I also see patients who really have both hypersomnia symptoms and depression symptoms, and they can tell me historically the two are on totally different trajectories. One will be better for a
Wow.
while the other stays just as bad, and then the other will get better for a while, and you know, the other is bad. They really seem unrelated. So I think that's one where the depression could
Yeah.
cause the hypersomnia could cause depression, or someone just has the bad luck of having both. I think that matters for a few reasons. I think it matters because there's probably really important information there about what's causing hypersomnia, whether it's hypersomnia related to depression or idiopathic hypersomnia. It's all happening in the same brain. And so there's really important clues there, I think. If we could understand that relationship, uh, I think it's not uncommon for people with IH on their journey to getting an IH diagnosis to be given a depression diagnosis.
Hmm.
Sometimes that's because they have depression, and sometimes it's because they don't, but their IH symptoms are being misidentified as depression. And so I certainly don't want to downplay the problem that is. I hear from people all the time how incredibly frustrating that is. But at the same time, like, depression is an important brain problem that we also need to understand, that we also need more research on, and that we also need better treatments for. So one, I think sort of the depression hypersomnia overlap is important from what it might potentially tell us about hypersomnia and its causes. But it's also just so important in terms of managing chronic disease, living with a chronic disease, coping.
Hmm.
It's really hard to have IH. It's even harder to have IH and depression symptoms, given the same severity of IH. And so I think it's really important to think about how depression symptoms can worsen IH symptoms, right? Depression can worsen sleepiness, it can worsen sleep inertia, it can worsen sleep durations. And so treating the depression is potentially going to help the IH symptoms, but it's also potentially going to help the depression symptoms, which also need to
Hmm.
be treated. Um, and so, I'm a big believer in tackling everything we can tackle, right? If somebody comes in to me and has a constellation of symptoms, I may not have, I never have, the cure that's going to fix it all. But if I can fix this little bit of it, and this little bit of it, and this little bit of it, that's still better than fixing none of it. And so I think it's important to keep things like depression in mind as a piece that's potentially treatable to help with quality of life. It's also messy because some depression treatments worsen sleepiness. And
Okay.
so,
Mm.
some sleepiness treatments have mood side effects. So it does require, I think, coordination with a psychiatrist. There are not too many sleep doctors who are psychiatrists. There's a couple, but I spend a lot of time calling my patients psychiatrists because I think that coordination of care is really important to kind of tackle both in parallel.
You've That's really helpful. Thank you. You've talked a lot about depression there, which I think, is something that's so prevalent and pressing and such a burden in for many people. What role do you feel like anxiety, particularly as a comorbidity, plays with certain people in our population, in our community?
Anxiety is a bit tougher because there's much less of a literature about anxiety and hypersomnia overlap. The depression hypersomnia overlap is big. Hypersomnia is literally a symptom of a number of different mood disorders if you look at the diagnostic manual for psychiatric disorders. Whereas that's not really the case for anxiety. Um, we do see that overlap sometimes. It can be particularly problematic because basically all the medicines that we have that can wake people up have anxiety as a potential side effect.
Hmm.
And so for someone who comes in with some pre-existing anxiety, it can really limit the medications we can use, the doses of medications we can use. I've even had people sort of realize in retrospect they thought they just had hypersomnia and anxiety, but when we lowered some medications, really realized the anxiety was a side effect all along. So definitely another important overlap, particularly from a treatment standpoint.
Hmm. Any other comorbidities that you think people should be aware of, that coincide with a long-term diagnosis of IH, perhaps?
Yeah, so another comorbidity that's been described by a number of groups in people who have idiopathic hypersomnia, but also narcolepsy type 2, narcolepsy type 1, sort of the sleepiness disorders more broadly, is dysfunction of the autonomic nervous system, or at least symptoms suggesting dysfunction of the autonomic nervous system. So the autonomic nervous system is kind of the background process that keeps everything running in your body, and people are usually familiar with the sympathetic nervous system. That's part of the autonomic nervous system. That's your fight or flight response. That's your, like, oh my gosh, there's a bear, and your body gets, fired up to react to the bear. Equally important is the parasympathetic nervous system, which is sometimes called the rest and digest system. It's like when the bear is gone, how you do the calm processes. And it's really important. The balance between sympathetic and parasympathetic nervous system is really important. It changes with different sleep stages versus wake. So, and because it's sort of the background for so many biological processes, there's actually lots of symptoms of autonomic dysfunction. The one that's been, I would say, most clearly described in idiopathic hypersomnia is what we call orthostatic intolerance, or difficulty regulating heart rate and or blood pressure when you go from sitting or lying down to standing up. So that should be a seamless process. People should be able to do that. Their heart rate and blood pressure should accommodate that. But when it doesn't, because of autonomic dysfunction, people will either get really lightheaded when they stand up, or have palpitations when they stand up, or just feel really ill when they're in a standing position. And that a number of groups have suggested is more common in people with IH than people without IH. It's, again, I think, an interesting question about what does that mean for our understanding of IH? Is that the primary problem, or is that just a consequence of having IH? We know that the more time people spend lying down, the worse some of that difficulty with changing positions gets. And so if you're sleeping 12 hours because you have IH, maybe the reason that some of those symptoms happen is a downstream effect of that. It's because of long time recumbent. We don't know the answer to that. The other way that I think potentially that symptom is important in our understanding for IH is there's sort of a cluster of symptoms that get seen together a lot in a lot of disorders. And the cluster can include dysfunction of the autonomic nervous system, this difficulty with changing positions, can include a lot of fatigue. So not sleepiness per se, but more of the weary, tired, fatigue component. And sort of depending on which constellation it is, there might be joint issues or muscle issues or GI issues or what have you. But you sort of tend to see these things clustering together. And we kind of are starting to see that in IH and sleepiness disorders also. We looked a while ago at our population of people with sleepiness disorders, and about 20% of them who we knew had diagnosed sleepiness disorders, narcolepsy, idiopathic hypersomnia, about 20% of them also met criteria for chronic fatigue syndrome. And so this overlap, I think, is important. We really don't have a great handle yet, although there's a lot of work being done on what those sort of overlap syndromes are. But I think at least some people with IH seem to fit into that overlap cluster. I am not at all convinced that IH is one disease. I think as we understand it, we may come to discover it's multiple diseases. And I wonder if that group of people with IH who have really prominent autonomic symptoms, really prominent fatigue, I wonder if that'll be an important subtype of IH that's sort of distinct from some of the other groups.
Can you see research going in that direction then? Because that's a really significant, 20% is not a small number, is it? When we think about people's sort of daily challenges, can you see research supporting that?
Yeah, I think it's important to sort of let there be a crosstalk between these different areas. And what I mean by that is sort of as more is learned about chronic fatigue, say, or as more is learned about autonomic disorders, can those of us in the IH research world apply any of those findings? Can we look for those same things in our population of people with IH, and do they relate to those symptoms in our population? And similarly, as we learn more about IH, what from that will be applicable to those other disorders? I think the people doing those kinds of work are, it's different groups of people, but the science is out there. And so I think just keeping in mind that some of these symptoms in our IH patients might turn out to be really important clues to the disease if we can stay abreast of what's happening in those other areas.
Yeah, that's really interesting. I'm not sure we've heard in our community a lot about that potential relationship between chronic fatigue syndrome and IH. So that's really helpful. Okay, what's next? What's next for you in terms of research, Dr. Trotty? Look, that brought a huge smile to your face. I knew it would. It's like, great. Let's talk about research. Oh, over to you. Absolutely, go for it.
So, like everybody in research, I like to have a lot of different things going on at once. But I will say my biggest project in IH right now is an ongoing study that's funded by the NIH, and we are looking at the medication clarithromycin in people who have idiopathic hypersomnia or narcolepsy. And we really are primarily trying to answer the question of, in people whose sleepiness gets better with clarithromycin, why are they getting better? So the background here is we did a study some time ago now that was just 20 people, all of whom were sleepy, half of whom had IH. And we had them, everybody took clarithromycin for 2 weeks and placebo for 2 weeks, and then crossed over and took the other one. And we didn't know, which weeks people were taking what. And while people were on clarithromycin, they were less sleepy than when they were on placebo. So we have a little bit of evidence to suggest that clarithromycin might help with sleepiness in people who have idiopathic hypersomnia. But obviously 20 people is not enough to base medical practice on. It was just a pilot study, right? So in this much larger study, our goal is to recruit 92 people, half of whom will get placebo and half of whom will get clarithromycin. And one question we're asking, of course, is, does the sleepiness get better with clarithromycin than it gets with placebo? And so we're using some of the same measures of sleepiness we used in the pilot study, but also some different measures of sleepiness in this study. But equally important is we're trying to answer the question of, in the people who get better, why do they get better? So lots of medications do more than one thing. Clarithromycin is one of them. So it is an antibiotic. And antibiotics change the bacteria that live in the gut. There is some work suggesting that sleepiness in other kinds of disorders might be related to the bacteria in the gut. We don't know if the bacteria in the gut has anything to do with sleepiness in IH yet or not. But it might be that clarithromycin works because it changes the bacteria in the gut in some people in a way that helps, because it gets rid of the sleepiness inducing bacteria. So that's one question we're trying to answer with this study is that true? Clarithromycin also turns out to be an anti-inflammatory medication, and we know that people with idiopathic hypersomnia are more likely to have kind of inflammatory allergic disorders. We know that inflammation in general makes people sleepy. And so it might be that the people who get better with clarithromycin get better because their inflammation is reduced. And so that's another thing that we're testing in this study. Some of my colleagues have come up with a theory that some people with idiopathic hypersomnia might be producing too much of a substance that activates the sleepiness-inducing GABA system in the brain. And we think that clarithromycin counteracts that system. And so that's another question we're asking with this study. Again, in the people who get less sleepy, are they less sleepy because of changes in the GABA system? We're also really interested in the connectivity patterns in the brain, which parts of the brain are active at the same time. And so we were looking to see if those connectivity patterns relate to changes in sleepiness as well. So, fundamentally, the question is, in the people who get better, why are they getting better? And that matters for two reasons. One is it may help us develop better drugs because we'll know new things potentially to target in addition to clarithromycin. But also, since we don't know what causes IH, if fixing one of these things helps with sleepiness, then you sort of work backwards and see, well, how abnormal is that in people with IH? Is that a subset? Is that everybody? So it might tell us something about IH itself.
Yeah, that would be incredible to have better disease understanding. I'm sure that's not your only project. Have you got anything else you want to share before we sign off?
We're actually really excited to be looking at some data from the Hypersomnia Foundation's CORD registry. We had looked at that a few years ago for just the first time people entered the registry, but now we are looking at what happens over time in people who have done the registry more than once. It's really a unique resource. There's not other data sets like that out there. So we are really excited about that as well.
Yeah, I'm glad that exists. And for our listeners, that's actually a registry that's open to everyone. It's on the Hypersomnia Foundation website. There are details that you can register if you are new to our community or are interested in participating in research. In fact, in my inbox this morning, I had several requests for people to access that. So it is alive and well, and I'm glad to hear it's a significant resource for researchers like you, Dr. Trotti. As always, thank you for your time, and it's could speak to you for ages and ages about so many different elements. This is really helpful. Thank you. We will circle back with you, I think, and keep up with your research, as you, I know, still want to be involved with the Hypersomnia Foundation and speaking at our events, and hope to see you actually next June, I think, in Houston, if not before. So thank you ever so much.
Enjoyed it. Thanks so much.